recording. Um, so I'd like to introduce Dr. Bill Tapp. He is the chief of the Sarcoma Medicine Center in New York. He has extensive experience in translational medicine and is currently in charge of clinical basic science and translational aspects of the Sarcoma Medical Oncology Program at MSK. He is also helping to develop a comprehensive adolescent and young adult cancer program at MSK. He received his medical degree from Jefferson Medical College in Philadelphia and performed his residency in internal medicine at the Vanderbilt University Medical Center in Nashville, Tennessee, and his fellowship in hematology and medical oncology at UCLA Medical Center in Los Angeles. And Dr. Tapp also has tremendous interest in global healthcare initiatives and affecting health disparities in underserved areas of the US and abroad. And we're so grateful to have you, Dr. Tapp. Feel free to project your slides.
Great. So thank you, Sydney, and the Life4F group for having me here today. And I really appreciate the opportunity to talk about what's been going on with Turalio and a little bit more about the food effect study that happened and then changed the dosing. And this was kind of a little difficult rollout for everyone in the sense of understanding what to do. So we're really just trying to bring together everyone and have a seminar so we can talk about it. My name is Bill Tapp. I'm a medical oncologist, again, at Memorial. And Sydney, thank you for the introduction. I really do have to thank Sydney because Sydney was instrumental in spending a good amount of time with me to understand what would be the most important things to talk about and really help with the slide preparation as well. So it's been a really nice collaborative effort. I thought what I would do a little bit is talk about tenosynovial giant cell tumor and how we started to develop drugs in this disease. The audience really doesn't probably need to know too much of an introduction of tenosynovial giant cell tumor, but for us, some of the things we'd like to think about this disease is what it looks like on a cellular level. And there were some major advancements, back maybe about 15 years ago already, where we started to understand some of the genetic changes that were happening in the causative cells for this. And what ends up happening is there's a cell, it's a neoplastic cell. So we use that word carefully because it's not a cancer cell. But this cell oversecretes a factor known as colony stimulating factor 1. And what that does is it actually recruits inflammatory cells to the area around it. And there are two types of this tumor. There's a nodular type, which is a really small tumor and often cured by surgery alone. And then in this picture that I'm showing you here, there's a really invasive type known as a diffuse type. And what made studying these tumors really hard is that the majority of the cells in a big tumor that you see are actually the inflammatory cells. They're not the causative or the neoplastic cell, and that's important. But we're getting a lot better at studying and understanding the disease. So hopefully we'll see more advancements in therapy come out. But what happens in this diffuse type, as many as you know, that it can really develop these large tumors. It can destroy bone, it can bleed, and for people with it, it can really affect the joint, range of motion, cause pain, and cause swelling. And although it's not a cancer, so it's not threatening someone's life, this diffuse type can really affect the trajectory of the life of someone's life, right? Because of the disability associated with this. So there was a lot of interest in understanding how we could use drugs to block this relationship between the cells that secrete the CSF1 factor in the blood and then the inflammatory cells that are attracted to it. And that's some of the things that we'll talk about today. And when we first started working with Turalio, which is pexidartinib, or at the time PLX 3397, it was almost about 10 years ago now. And we started to look at this drug in cancer clinical trials because we were interested to see if this drug could really help in certain cancers. And that's important because we develop drugs for cancers slightly differently than we would develop drugs that maybe are more of a inflammatory medical condition. And the way we do that is we try to find the highest concentration of the drug that's safe to give people. And the thought is that the highest concentrations are often the strongest concentrations and would be the most helpful. Although, there are signs that this is not always the case, depending on the drug that we're trying to use. And so that was done, and actually 1,000 milligrams of pexidartinib was found to be what was recommended for future studies. And again, it was thought to be for cancer studies, and that was going to be in divided doses, which was 600 milligrams versus 400 milligrams. What was really exciting and interesting, and also caught us a little off guard early on, was where we saw the best signals of the drug was in tenosynovial giant cell tumor. And we saw these large responses, and these are just some of the curves that we look at when we look at the data to actually show that people with this diffuse tenosynovial giant cell tumor who used the drug had these dramatic responses. So the tumor really shrank, and as long as they were on the drug, that lasted for a long time. But in all honesty, tenosynovial giant cell tumor was a disease that was only being newly described. And it wasn't something that we as medical oncologists saw all of the time. It was a disease that was really treated often by orthopedists and orthopedist oncologists. So the medical oncology community really began to scramble to try to figure out how we could best develop this drug and get it out to people. The most important thing that I think happened was there was a lot of time with medical oncologists getting together with orthopedic oncologists to understand the disease, but also working with patients and patient advocacy groups, because this is a disease that will affect each patient differently. And it's not only based on the joint that the tumor develops in, but how aggressive it is in that joint. And then also how big the tumor can be and the symptoms that can come. And what we found early on is that this is something that often happens in young people, was misdiagnosed. A lot of people spend times in doctor's office, maybe being dismissed with symptoms or not coming up with a diagnosis. And then even when they had a diagnosis, it was something that, as you all know, people would have to deal with for years and years and years, and it could totally change the trajectory of what they were going through. And this was really important because when you're developing a drug, especially in a neoplastic process, it was important to show not only that tumors can shrink, but that was meaningful for patients. And so the medical oncology community spent a lot of time meeting with patients and trying to understand how the disease affected them, but importantly, trying to figure out how we could come up with object measures to really understand improvement in symptoms, right? And this was difficult because, again, of the variability of how the disease could affect people. But fortunately, our orthopedic colleagues have spent a lot of time understanding different joints and ailments in different joints and knowing how that affects people. So we were able to develop what we call some patient-reported outcomes. So people could actually tell us how they're doing and whether or not the drug helped them. And we could also look at things like range of motion, and we can look at things as pain. So that was really important. The other thing that was really difficult in first studying these tumors is that the typical kind of size criteria that we use to measure tumors doesn't really work well in tenosynovial giant cell tumor when it's really diffuse, especially early on, because the tumor can be outside of the parameters of those measurements. So a lot of time was spent in trying to understand appropriate ways to look at the disease. And this is just an example of a patient who was on the first clinical trial with this large tumor. And what you can see is when she used the drug, very quickly the tumor shrank. And a lot of thought was put in to say, how can we actually measure that shrinkage? And why is all this important? Because tumor shrinkage is important in the disease. Symptom management is very important in this disease, and they usually correlate, but they don't always. So in other words, sometimes you can have a small shrinkage in the tumor, but a dramatic improvement in symptoms. And when we talk in a little bit about how to use doses, what's the actual goal with the amount of drug you're on, it really comes down to an individualized level to understanding what the drug needs to do for you, right? And that's critical. And when I work with my patients, that is the most important question that we ask. And honestly, a lot of my patients who are involved in the development of pexidartinib really helped us understand how to use the drug, because they were really telling us how to use the drug for them. One of the struggles that we came about was understanding how to design the trial to actually get the drug approved. And there was a lot of thought that went into this. We were a little hesitant to use really high doses of the drug because, again, we weren't fighting a cancer, but we wanted to see the drug help people. And we were also basing it, like I mentioned, on some traditional measurement criterias that we have to use in clinical trials that aren't the best for this disease. The other important thing is, like I mentioned, we don't always understand the natural history of these tumors when we first start studying them, right? So when we designed the study, there was a lot of thought of needing a placebo within the study. And this is really critical because in an inflammatory condition, oftentimes you can see sometimes spontaneous regressions. We wanted to make sure that everything we saw on the study was actually going to be related to a response to drug as opposed to the natural history of the disease. But by adding in a placebo, we didn't want people to be on placebo for a long period of time. So we really tried to look at how people did over about a 6-month period. And then after that 6-month period, everyone could get drug. But this was a risky design in a study because we were really basing all of this on a very small data set from that phase 1 study. It was only about 30 or 40 people who went on the trial. And we were trying to really show dramatic improvements by seeing these tumors shrink, but again, using a criteria that wasn't necessarily right for the disease. But what was nice about this study is we built in a lot of other measurements. So we have to thank people who went on this study because ultimately they also had a lot of homework. Not only were they taking the drug, but they were talking about their symptoms, their pain, they were undergoing measurements of range of motion. But it really helped us show a few things in the trial. One is that drugs that target this are really effective. And these are just, again, what we call waterfall plots. But what you can see over time is that, you know, by 6 months out or even a longer time out, the majority of people who are using the drug had dramatic improvements in the size of their tumor. And that black line is really showing greater than a 30% reduction in the size of the tumor, right? So, but what you can see is that almost everyone had tumor shrinkage. And this is just an example of a lady from Milan who had a really bad synovial giant cell tumor in the hand. And you can see how well it improved. But what was important is that regardless of the depth of shrinkage that we were seeing in these tumors, almost everyone on study also had an improvement in symptoms. And that may be an improvement in the range of motion or their reported symptoms, right? So that's really important. So again, I wanted to kind of set that principle as we begin to move on a little bit to what's been happening with this food effect study and the change in formulation. So because of these data, the drug was FDA approved in 2019. The label is specific for people who have symptomatic tenosynovial giant cell tumor that's associated with functional impairment. And importantly, surgery is not right for them, for a lot of different reasons. And because the trial started at 1,000 milligrams, but everyone ended up after 2 weeks on 800 milligrams, trying to lower the dose for people, the 800 milligrams actually became the FDA approved dose. And it's divided in tablets. The tablets were 200 milligrams. So you would take 2 in the morning and 2 in the afternoon or evening, excuse me. And with most of these drugs, arbitrarily, what ends up happening is we want the drugs to be taken on an empty stomach. So we usually say 2 hours before eating or 1 hour after eating. And again, when you're taking the drug twice a day, it takes a lot of time management to figure out the exact time to do this, right? So is adherence for everybody like this? Probably not, right? Because of the practicalities and the education that people get about a drug. But the label specifically asks for 2 hours before a meal, 1 hour after, so you're truly on an empty stomach with it. Overall, the drug is generally well tolerated, but it does have side effects, right? And these are some of the side effects. It can definitely cause some laboratory abnormalities. We can see increases in some of the liver enzymes showing some inflammation in the liver. This is kind of a normal, addressable side effect that we see. It's just where the drug is metabolized. It can sometimes lower the white cells or increase someone's cholesterol, cause some anemia. some of the clinical signs that we saw or symptoms that we saw could be that it could increase the blood pressure, it could cause a rash, it could cause some swelling generally around the eyes, sometimes within the ankles, and it turns your hair white, right? So people taking the drug really know this. But generally manageable side effects. What I found is interesting is that a lot of people who start the drug, the side effects are not that meaningful for them early on because they're also dealing with a very difficult disease. But as over time, the drug really can help with the disease. Sometimes taking the drug becomes pretty hard, right? Because it's more invasive in your life. And so it requires thought with your clinician about whether or not you need to be on the same dose you started with, right, to actually control the disease versus what happens after the disease responds to the drug. Is there a way to use the drug in a way that's much more compatible to, going about daily life, right? So that's really important. There was one major toxicity of the drug that I didn't mention there, and that's different than liver inflammation, but was actually a liver toxicity where it affected the bile ducts within the liver, right, and how the liver could process bile. And it's what we call a cholestatic hepatotoxicity. It's also known as a vanishing bile duct syndrome, and it was really rare. And for a few people, it was very dangerous, right? So this was something where there was a lot of time spent to try to figure out why it happened, which we don't understand, or could it be predicted? And it wasn't something that was generally predictable. So because of this, the FDA, rightly so, with the company, mandated a REMS program, or a risk evaluation mitigation strategy. And this was important for three reasons. One, it made sure that anyone who was writing a prescription for the drug understood the risks of the drug and had to actually be certified, as did a pharmacy. The pharmacy also had to be certified to make sure that the providers actually knew what they were doing in providing the drug. The other thing is there had to be good information and education for patients. And then there was a mandate to really watch blood work closely. And so patients would have to come in many weeks and get blood draws. So you could really look at the liver function, and make sure that there was no signs that the drug could be hurting them, right? So this is the REM sign that if any of you are on drug, you signed up for, just like many of your providers did. But it really is important because we have to be very thoughtful in who and when we use the drug and how to watch out for it. One of the things that happened when the FDA approved the drug is that they brought up concerns as to what would happen in people if they didn't strictly follow the empty stomach component. In other words, if they took the drug closer to food. Why? Because we often know that if you take a drug with food, sometimes it can affect the concentration of the drug in the body, right? So you may be getting a higher dose potentially of the drug than you actually think, right? So to understand this better, with a lot of the oncology drugs we use, we perform what's known as a food effects study. And what a food effects study is that we try to give drugs with known quantities of fat to actually understand how the food would impact how the drug is absorbed into the body, right? And what is it about the food we eat that could affect this? And I said fat, but there are different components of food as well that could potentially affect how a drug is absorbed. So specifically with Turalio, there was a food effects study in which there were volunteer patients, or volunteer people, I should say, because they're not always people who have the disease. Sometimes they're just regular people. But they can also have TGCT as well. And they were broken down into three groups. So one group of people actually took the drug on an empty stomach. One group of people actually took the drug on a low-fat meal. So this is actually like a prescription meal where you know exactly the fat content that you're getting. And in a lot of circumstances, the meal is actually provided for you. And then one group of people actually took the drug with a high fat meal. And then what happens is after you take the drug, you remain in the clinic for a period of time, and the levels of the drug can be monitored in the blood by actually taking the blood, right? So sometimes, depending on the study, you can get blood drawn several times that day, and then days, following, to actually know what's happening to the drug and how the drug is being metabolized in you. This is just an example of some of the meals that people took. So there was the high fat diet, right? And the high fat diet are, foods that we love to eat, right? So this is going to be like eggs fried in butter, bacon, right? Toast with butter, hash browns. The low fat diet was very controlled. You were trying to get fat within around the 11 to 14 gram range, right? So this is what we would consider a healthier diet in the sense of breakfast, right? So again, well prescribed and consistent within the people who took it, so that they can actually monitor the effects of the drug. And then, as I mentioned, what happens is blood is drawn serially over time, and you can actually measure the amount of drug that absorbs in the blood over time. And what the study actually showed is that the more fat you eat, the more drug gets absorbed into your body, right? So this becomes important because if you're not adhering to the original guidelines, which were to take the pill on an empty stomach, what could really happen is that you may be getting higher doses of the medication than you would think. And this is just some of the data that came out, and I'll kind of walk you through the curve. So this is the amount of Turalio in the blood, and this is time, right? And it's going from hours, so 0 hours, out to 144. And what you can see is if you took the same dose of Turalio, which the blue is 400 milligrams on an empty stomach, it kind of comes up and then comes down. But if you actually took the same dose with a high fat meal, you get a higher peak within the blood, and it remains in the blood longer. And this curve over here to the right is just, we stretched out this here, which is the time, right? So it really comes down to here within the first day. You can see you get a higher peak of the drug in your body, and then over time it takes longer to come down, so you get more of exposure. And if you can imagine, if you did this every day, the drug can reach a higher, steadier state in your body over time, right? And this is just another example of this, where if you took, say, 400 milligrams on a low fat diet, this is this gray curve, it's just about the same as taking 200 milligrams with a low fat meal, right? So it's just showing that, excuse me, I didn't explain that right. But what it shows here, if we have the blue, which is taking 400 on an empty stomach, versus the gray, which is if you're taking it in a low fat meal, that dose is a lot higher. So if you actually look at 400 on an empty stomach, it's the same as taking 200 with a low fat meal, right? So if you take 200 with a low fat meal, you are almost doubling your dose just by taking it with a low fat meal, right? So showing the effect that the food has actually on the drug. Now, why does this happen? Well, there's a lot of things that food can do to affect drug absorption. It can affect stomach acidity. It can affect the volume in which the drug is being emptied from the stomach into the intestines. It could delay how quickly the drug moves through the digestive tract. It can increase digestive proteins or absorption. So there are a lot of things that can actually happen with the body's attempt to metabolize the higher fat diet that can affect how the drug itself, which is taken with that diet, can actually increase into the blood. So because of this, there were concerns with the higher dosing formulation that if people were taking it with the wrong diet, they could really get overexposed to the drug. And why was this concerning? Because we don't know if higher concentrations of the drug would have put people at risk for not only more side effects, but even some of the more dangerous side effects that I mentioned before, such as the cholestatic hepatotoxicity, right? So what the company decided to do was to actually change the formulation so that we would have a lower amount of milligrams within a drug. So instead of 200 milligrams, they made 125 milligram tablets. And they asked the drug, they're asking us, the patients now, to actually take the drug with a low-fat diet, right? So the thought is that 125 milligram tablet with a low-fat diet, 11 to 14 grams of fat, is similar to taking a 200 milligram tablet, but there's less concerns for toxicity if you do not always adhere to that specific diet, right? So that was the important part of it. So that created this label change where in the past, people were at the maximum dose taking 400 milligrams twice daily. You would now be asked to take 250 milligrams twice daily. And the thought is that it could be a one-to-one exchange of the 125 milligram tablet with the 200 milligram tablet that you're on, right? So if you were taking 3 200 milligram tablets, you would take 3 125 milligram tablets. And the key was that no longer are you being asked to take the drug on an empty stomach, but now being asked to take it with a low-fat meal, again, of approximately 11 to 14 grams of total fat. And I spoke about this a little bit. It's supposed to be a one-to-one change within what you're taking. And this is just a chart, which I think is nice, which kind of explains how you're doing it. So if you're taking 600 milligrams of pexidartinib in the old formulation, so 200 in the morning, 400 in the afternoon, you would now take 375. So 1 tablet again in the morning and 2 tablets again in the evening, just the lower dose. So this is important. I think I'm going to talk about this in a little while, but most people who are on Turalio have found a dose that works for them, right? So it's really trying to find the right substitution with the new formulation, but it should be a one-to-one equivalent. For people who are just starting the drug, hopefully this wouldn't be as much of an issue, but it's starting at a drug, again, that's right for you. And some people actually start at the FDA recommended dose, which now would be the 250 twice a day. Some people actually start a little bit lower, just based on what is really the goals of the effect of the drug. So it's really important when you're taking the drug to really think about what a low-fat meal is. And sometimes it's easier to work with a nutritionist, but there is going to be some fat content counting that happens here. And how do you come up with the right food for you? You know, what do you like? What's your daily routine? How hectic is your life? How easy it is to do this, right? This becomes really important. But these are just some examples of what can add up to that 11 to 14 grams of fat. So a lot of my patients now, we actually try to think about what works for them. In a weird way, though, it is giving patients some flexibility, understanding the food intake and the amount of drug that they're on, to think about what is going to be the right dosing for them and the right meals for them, right? So it's really important to work with your providers about this, and maybe even seeing a nutritionist to coming up with the right schedule for you in the sense of the amount of drugs and the meals that you eat, to make sure that you're on a dose that's working for you, but truly understanding the goals of that dose and how that changes over time, right? And that becomes really important. So I wanted to end with about a half hour worth of questions, because I imagine there's a lot of questions out there. And again, I want to thank Sydney for putting together a lot of the concepts and the slides. And I hope that was, a reasonable talk to start the discussion.
Thank you so much, Dr. Tapp. You did a great job. And as you can imagine, we do have a lot of questions. So we'll start with some of the live ones as well. And so one patient said, or asked, what is the long-term effects of the drug use? Do we know more about maybe fertility issues and other issues long-term?
Yeah, it's a great question. I've had some patients who have been on drugs since the initial phase 1 study, so going on many, many, many years right now. I don't know if we've necessarily seen emerging toxicity or long-term effects of the drug. So we don't know. We don't see any dramatic detrimental effects happening, but it's still an unknown because this is a drug that's only been recently approved. I think the bigger question is, do people need to be on the drug for long periods of time? And I think once a drug like this gets approved, we're trying to answer that question. And we're trying to answer that question with patients. And I'm seeing a lot of variability. Some people can have really dramatic responses. We can stop drug and keep people off of drug for long periods of time before we see things grow back, or if we see things grow back. And I've had other patients where we stop drug and all of a sudden the tumor starts to grow again. But we don't necessarily need to think about restarting drug right when the tumor starts to grow again. A lot of times there's a long period of time before we actually need to think about starting a drug. There are some people that are looking to use the drug and really affecting the tumor, then questioning if they should go to surgery. There are some people that are staying on drug, but using a much lower dose, hoping that it's safer. So these are the things that we're trying to define. But having a good drug for these tumors, and also knowing that this is not a cancer. And why is that important? Because cancers tend to be really genetically complex, so they can develop resistance to a drug with longer term use. That's not something we're seeing here yet. So what that means to me is if we stop a drug and the tumor starts to grow again, there's a very, very high likelihood that if we start the drug again, the tumor will respond. So it seems to be relatively safe for the long time, understanding it has a similar side effect profile as we've seen in the beginning. The effects of fertility are not necessarily known in the long term, but there are some side effects that you can see. You know, there can be some slight memory changes, cognitive effects on the drug, which are also all concerning if you use it for the long term. So the goal is really to understand, what are your needs? What are the symptoms you're having with the drug? How is it working for you? And then are there periods where you could think about lowering the dose of the drug, or maybe trials of stopping the drug to actually see how long an effect of the drug would be.
Perfect, thank you. Also, I think your slides are still sharing. I'd love to see you closer up if I can.
I don't know if I can figure out how to stop sharing here.
There should be a button
Oh,
at the
there it
very,
is.
yeah.
Okay, got it. Thank you.
So I think one of the much anticipated questions, and kind of what prompted us to ask you for this webinar, was that some patients are told that there is a recommended fast for maybe higher fat food, or what would constitute your low fat food becoming a high fat food if you eat right after. So do you have maybe some recommendations for patients on when, if they're going to eat a big burger with lots of avocados that go over the 66 grams that become a high fat, how long should they wait from their low fat meal?
Yeah, that's a good question. You may have some suggestions too, but I think we have to be a little careful, because we can't be so rigid with recommendations, because again, people are out there living life, and that's where we want with the drug. But I do think that if you are eating a really high fat meal, I would rather people wait to take the drug, because that can really increase the concentration of that dose. How long you wait is a little more difficult. We speak to some of our patients about waiting an hour, or, sometimes even skipping a dose, which in the big scheme of things is not going to affect things, but you just want to make sure that it's safer for you. It also, what I found with a lot of my patients is they've become really familiar with their dosing, how they take it, and how meals affect how they feel, right? And what is their threshold for beginning to see side effects on the drug. And I think it also depends on what dose of the drug you're on, where, we have to be much more careful if you're on the maximum dosing of the drug versus a much lower type of maintenance dose of the drug, right? But I do think if you're going to eat a really high fat meal, err on the side of caution, so you're not getting that bolus within your blood. I don't know, Sydney, if you've heard other recommendations, but.
Oh, I've heard plenty. From my understanding of the labeling and the data I've seen, is that there's no concern per se with lower fat meals in closer proximity within an hour or so. The concern is that really high fat meal. And as you said, it depends the dose you're on. And I've seen the modeled data, which we didn't really show because as many of you could understand, simulated data is hard to understand and it's hard to present. But that the results are that's why there's no recommendation for a fast, I guess, because
Yeah.
there's dependent on the person and the clinician.
Yeah, and we often tell our patients when there's a switch like this, sometimes it's really good to try to achieve the steady state. So doing things as they're recommended for a few weeks, just so you really understand how things are affecting you and how you have adjusted. And then, it's easier to say, well, if I am going to have this high fat meal, I'd understand I need to either delay taking the drug or skipping this dose for a little while.
So similarly to following the recommendations, some providers recommended patients not consume things like alcohol. Is there a firm recommendation on things like alcohol?
Yeah, I don't think there are any firm recommendations. I also think early on when you're starting a new medication, especially one that's metabolized in the liver and you can see some liver inflammation, it's probably better to stay away from alcohol or use alcohol in moderation, because that can often affect the interpretation of what the drug's doing in the body and the side effects. And I also think we don't know much about what causes this cholestatic hepatotoxicity, which we say is idiopathic, which basically means we don't know, right? So, avoiding any, other agents that could cause liver toxicity at that time may be important. It's a lot different, I think, when you've been on drug for long periods of time, you understand how it affects you. Excuse me. I mean, I think moderation is always the key, right? And again, understanding of when you may be having a drink and when you're taking the drug as well. I'm not a big fan of, doing it in close proximity for the reasons that I mentioned before.
And most of that mixed cholestatic hepatotoxicity and other more concerning side effects occurred early, right? Within the first 3 months of therapy.
Yeah, that's exactly right. It occurred early, and it happened mostly in people that were on the initial part of the study where they received the higher doses, the 1,000 milligrams for 2 weeks. It didn't seem in the people who were on placebo and crossed over to the 800 to see it, but it was definitely something that happened early. And that's why the REMS program looks to test blood, serially for the first few months. And why I also think that's the critical time to really just be a little careful with what else you're doing, just to make sure the drug is safe.
Perfect. So there is a patient that's talking kind of specifically about her situation, but it's one that's very pertinent, is that a patient is young, childbearing age, and would like to start a family one day. Do you have any recommendations for patients? Majority won't have a complete response, right? Many of them have.
Yeah.
When should they go off? How should they go off? And how could they lower their risks when they want to have a child?
Yeah, so these are really tough things. And again, I want to be careful that what I'm offering here is general advice. Most importantly is to, speak with your providers, and in the sense of whether or not, what is the right timing to have a child, right? You really also want to bring in fertility counsels to this. So we worry with drugs like this that the drugs could be toxic to the developing child, right? So we try very hard to educate people not to have children while you're taking the drug. There's a little controversy over, what is the right time to be off of a drug, and many people feel that it's about 6 months, being off of a drug before thinking about conceiving. And this is a disease, as we know, that does affect younger people. It does affect a slight, preponderance of females. So it's a question that we get all the time. I will say that many people have learned to live with the tenosynovial giant cell tumor, right? So we often discuss whether or not we should be starting a drug. And I've had a lot of patients that have deferred starting the drugs just so they can have children. And then when they've decided they don't want to have children anymore, then they will actually start the drug. Other patients have gone for a surgery, and that really has allowed them to have periods of time where they can also have a child, but not really have the symptoms of the disease. But if you're on a drug, we really would recommend stopping the drug for about 6 months, before trying to have children.
Thank you. So as we collect more data, the time from approval continues to tick away. what data would be needed to either get the drug off the REMS program, if that's a possibility, and that we know more about the side effect profile with food? Like, does the food itself change the side effects? And then what would be needed to get off REMS?
Yeah, it's a great question. I don't know the trigger of saying what will get, patients where patients won't have to have a REMS program. And I do think there is some risk about stopping the REMS program. In a rare disease, I just don't know if we would get enough data. The other thing is that this is a really rare disease, so that, most oncologists are not, familiar with it or used to treating it. And that means most oncologists are often not used to using a drug like pexidartinib, right? So in part, the REMS program also adds this layer of security to make sure that people are educated. And in my mind, it's interesting because you spend a lot of time trying to get a drug approved, and then you get the drug approved, and then you spend a lot of time trying to figure out reasons not to use it, right? So it really has to be right for the patient, and you have to have real transparent discussions about that. But in a rare disease, and knowing with the variability of data that we collect in the real world, right, it would probably take a lot of time, a lot of patience to show it's safe. The other thing is, a lot of patients and providers, when the drug became available, made the decision to start at kind of the half dose. Of the old dosing, it would be about 400 milligrams. Now 250 milligrams. And the thought is that you don't need these quick and dramatic responses in most people that warrants potentially being on the higher dose, and the doses that may cause some of the liver injury. So that's an interesting concept, right? To start at a lower dose and really help improve symptoms, because as I said, you don't necessarily need dramatic early shrinkages to see improvements in symptoms and quality of life. And then you can always adjust the drug up or down. But when we've also spoken about that, we don't know if by starting at a lower dose, does that affect the timing of the cholestatic hepatotoxicity, if it's going to happen, right? So I think having that close monitoring remains important, just to be careful. I know it's difficult and inconvenience at times, but, I think it's much more important to be safe.
So talking about safety and toxicity, do you have patients, or is it common for patients currently to discontinue due to toxicity? And has there been any mixed cholestatic toxicity found since the approval?
Yeah, it's a good question. I don't know of any. I definitely haven't seen it in my patients, but that's not going to be a comprehensive analysis, but I haven't heard of any, right?
We haven't published any, if that helps.
Yeah, right. So it's hard to know, but again, I say that with caution, because I don't want people to and providers to be more cavalier, right? I think it's really important, again, to show it's safe. But I will say, like I said before, and this is not a trivial thing, is that sometimes when patients start the drug, the effect of the tumors are just really debilitating for them, right? And in that case, they're more willing to tolerate, these side effects that are otherwise bothersome. But what happens is, as what I've seen is that as the drug really helps and the tumors respond and quality of life comes back over time, it can be these symptoms that weren't as bad early on that just become more prominent in people's lives. And that's what can cause people to stop drug. I think what I've also found is that over time, there's this struggle in the decision to make, especially if people have been through a long period of a difficult time with the disease. Is it worth stopping it and see what happens, versus saying, should we lower the dose and try to find a dose where we really don't see side effects, but maybe helping? And I think this is where the personal effect of the drug and the management comes in, understanding what's right for the person, the goals, how the disease has affected them, becomes really important in making decisions if you want to lower the drug and then stop versus stop the drug. But I will say, it's nice to know that the drug is there, right? We can always start it. And dramatically in the last few years, there's a lot of different treatments coming out for, tenosynovial giant cell tumor, which is just wonderful. So there's a lot of hope in this disease.
Thank you. You also mentioned some people trying to lower their dose for long-term maintenance, where they may start out at a higher dose and then go lower to try and mitigate some of those side effects. As this is all happening and data is being collected, is there somewhere that's being stored and then therefore published? Is there studies going on?
I wish. but it becomes difficult because most of the times these are just personal decisions between a patient and their provider, or sometimes even the patient, making decisions alone. And that's a lot harder to capture, right? Because it's not in any controlled type of study. I will say in rare diseases, we're beginning to work on efforts where we start collecting real world data from medical charts, right? And we may be able to pull that out. But unfortunately, all of this is just anecdotal. And again, it's what happens with any drug gets approved. The approval process is in a really controlled fashion. But once drug is on prescription, you have a lot more leeway to use the drug in a way that's correct for the individual, right? So there's a lot of decisions that are being made on a personal level, often by patients. And I have a lot of patients that come in and say, well, the last 2 months I decided to do this, and they're the expert in that, right? So as long as it's not, as long as it's always in a safer and more conservative way, that's always fine. But it's going to be hard to collect that data until we get better with data extraction for medical records. So I will put that out there to this community. This community is what helped us understand the disease, helped us to understand how to develop a drug correctly, got the drug approved. And I will say emphatically that that collaboration with patients is what got this drug approved. We need patients to help us understand how to appropriately use the drug, right? And we're very honest with that. And I'm very honest with all of my patients. We don't know how long to do it, when to stop, do you go to surgery, what dose to use, right? But that's really, hopefully, what we can collect by continuing to work with all of you.
So the overall message is patient-centric approaches. That seems to be the trend in teaching.
It is, and real discussions with your, provider, and but really understanding what the drug does, good and bad, and what is important in life, and understanding of the disease before drug and how it affected you. I'm a big believer, sometimes the smaller lesions in elbow, wrist, sometimes really stay stable. More diffuse lesions may grow, but I've seen patients with really big tumors be off drug for 2-3 years before it started to grow again, right? So it's different for everybody.
So many of the patients have learned about these changes through TGCT support, as well as some of their doctors. But what we've seen is there's kind of a gap in the educational strategy and tools for providers and patients alike. Do you know of any ways that their doctors or this information can be conveyed to them from the medical side as well?
Yeah, I think a lot of it, from our side is probably going to come out in CMEs and certain training where there are going to be lectures. There are the standard information that's now being generated by the pharmaceutical company and is presented out through the medical science liaisons that meet with them. But I do think the education of people and patients is really important, and bringing that to your provider and having discussions with them is critical, right? Because this is something that, like all rare diseases, I think patients being informed can really inform practitioners, and again, have the discussions of what's right for them. So it needs to be a full prong approach of education. I think seminars like this are also so important, because this is where we can really begin to set some foundation of what needs to be done.
Wonderful. Yeah, patients are definitely in this community very happy to help their providers figure out the best thing for them.
Yeah.
So we've gotten a lot of questions as well about going from Pexi to surgery, back to Pexi, or having surgery and then immediately going on Pexi. Do you have any? I know MSK is one of the leaders in that sandwich approach.
Yeah.
But do you have any interests or data or anything relating to that?
Yeah, mostly anecdotal, where we've had patients who are on pexidartinib and had surgeries and then, went back on drug, right? And I think some of the original thought is that if you could really shrink the tumor, that would allow for a comprehensive but not a morbid surgery, right? I think there is some thought that may really more eradicate the disease, although there's newer data coming out to suggest that pexidartinib may not target as deeply that neoplastic cell as we want, right? So it's very possible that there could be components of that cell that is still around, and that could surgery get rid of that? Possibly. But it's something that we really have to study. I actually think if we didn't see the cholestatic hepatotoxicity, those would have been the types of studies that we would be able to do. But I think all of those approaches are something that you can talk to your provider about, right? Whether or not it's right for you or worth trying. And I also think what's interesting is with newer treatment modalities coming out, there may be some other thoughts about how to really provide for a more thorough and comprehensive surgery in the sense of what that could done for this disease, right? So important.
So we also see often in cancer and oncology that toxicity is really associated with the effectiveness of the drug. Because you have that toxicity component of Turalio with the liver enzymes, is there any relation to just the liver enzyme inflammation and maybe how much elevation you have and how you feel or how you function?
Yeah, not that I know of. And I think what I find is very variable from person to person. There are some people who can be on high doses of drug and not know they're taking it, and some people who, are barely even seeing the drug and having some side effects. And it probably has to do with, how an individual metabolizes the drug. So I don't think, we always equate the toughness of the drug with the efficacy of the drug. And that's not the case. Even when we use chemotherapy in cancer, we know we're going to have side effects, but I'd rather not have side effects. And I think with a drug like Turalio and a disease like tenosynovial giant cell tumor, the goal would be to use, the least amount of drug that is achieving your goals, right? And a lot of those goals should be disease control and symptom management. And if you can find a dose that does that without any side effects, that's the win-win. But that's really, should be the goal, right? So there's no reason to withstand side effects, especially once the disease is controlled, right? I'm a big believer that probably lower doses can help maintain the tumor. And be much more manageable on a day-to-day basis.
So once tumors decrease and maybe a patient has benefit from it, do you ever recommend just entirely stopping and
Yeah,
seeing
yeah,
what
yeah,
happens?
yeah, definitely, depending on the disease. And I will have to say, most people don't need a dramatic shrinkage to see symptom improvement. And that's why often, we don't start at very high doses because, there's no reason to come in and you need to see that shrinkage in the picture that I showed you, which in 2 weeks, you're seeing dramatic changes. But if you can start a dose and see improvement in symptoms, and then maybe over the course of a month or a few months, you start to see the tumor shrink. Well, that's really valuable, right? But it's sometimes easier with these drugs to come in at a lower dose, better tolerable, and then you can adjust it up or down as you need it. Sometimes when you start at higher doses and side effects hit you, you have to spend more time off drug or really lowering drug to manage the side effects. So it takes longer to get an effect.
So for going back to the food effect, there's a lot of people that are super excited about getting to take Turalio with their coffee and milk now in the mornings. Coffee, as many of us know, has a component of caffeine, which does affect drugs. Do you
Yeah.
know of or consult your patients about caffeine possibly impacting the absorption?
I don't know of any data surrounding that, right? So again, I think it's all in moderation. And I also think it's understanding your routines and how that affects how you feel on drug, right? So that becomes really important. And most people know that. And again, I hope, most people are on doses that are not going to be at the maximum dose where there's a little bit of a wiggle room in what happens with that absorption with a single dose. But I also think, to your point, it has to do with, what are you putting in the coffee? Are you putting in a lot of creamer, which could be more of a higher fat content than, drinking it black or with skim milk, right? So these are the things that you should think about a little bit.
So we also had a patient ask, so if patients have improvement on lower doses, Are you worried about the tumor continuing to grow and cause issues with maybe bone health or the joint health?
No, I don't think so. I think if the drug is controlling the disease, I think I don't all of a sudden expect to see something negative happen over time, right? But I'll tell you, in our clinics, I try to have all of our patients with tenosynovial giant cell tumor to see orthopedists as well, right? Because there's the difference of what the tumor is doing and the symptoms it is, but also the bone health, as you mentioned, right? Because you want to make sure that, especially at presentation, what are the goals of treatment? And sometimes the goals of treatments are actually to prevent bony deterioration, right? So people won't need a joint replacement down the line or quicker. So having the orthopedist weigh in about that is really important. But generally, if you're finding lower doses are working for you, that's a good thing.
Similarly, should Pexi be taken the 12 hours apart exactly, or is there flexibility on when you take it as well?
Yeah, I think, we talk about, a twice daily dosing. So there is going to be some flexibility, again, with the understanding that if you take it really close together, that, that's probably a little bit more dangerous in the concentration. But, it doesn't have to be clockwork all the time. I mean, understanding how, people live lives, right? So it's a lot harder to do things. And there's a lot of common sense that goes into it. And again, for most people, it's okay to miss a dose here and there. It's okay to take holidays if you have side effects or if you're going on a vacation. This is kind of a longer term commitment to the drug, and always err on the side of caution, right? I think that's the key.
And we'll save the last question, which is kind of a fun question we always have within the groups, is that hair and skin obviously are a side effect and a big change with
Yeah.
Turalio. We see that only 67% have hair changes. One, have you ever seen someone without it? And do you know the reason for the hair and skin
Yeah.
change?
Yeah, so I think the reason is because of the off-target effect on wild-type KIT signaling, which is important for melanin production. So there's two things about that. One is, the hair is, not a trivial thing, right? It's definitely a cosmetic thing. You can definitely dye your hair. It doesn't affect, that, but it is definitely something, that bothers people. The skin hypopigmentation is important because it can also make you more sensitive to sun and sun burning. And, for certain people, it can also have cultural effects if the skin is being lightened. So it really is something important to really talk to people about. I've never seen it not happen. So I always wonder, is it someone who was just dyeing their hair or didn't come out or what? But, it is pretty prominent with this drug, but it's kind of an off-target effect from what we mean is off-target is these drugs can have different targets that they work on. The target we're interested in is the CSF1 signaling, but it affects other things too. It's just a different target for what we need for tenosynovial giant cell tumor.
Well, thank you. Yeah, I have also never seen someone who didn't get the whitening of the hair. So it's always been a funny joke within the group of that they're hiding.
Right. Right. But it's it was interesting too, running a placebo controlled study, right? When everyone knew very quickly if you were on drug or not, right? But I also think, it's something, it is one of the symptoms that really affects people, and it's not a trivial symptom, right? That when you see that. So these are things to discuss with your doctors in the sense of length of time taking drug or dose, right? Because maybe that's all meaningful. So it's whatever most important to you that should come into the conversation about, the dose and the timing of the drug.
Have you seen people's hair get darker as they lower dose as well, like a concentration dependent effect?
Yeah, I have. And definitely if you stop it, in the old days with drugs like Sutent, when we did 4 weeks on and 2 weeks off, we actually pluck hair and, eyebrows, and you can actually see, white and then dark and then white. So it is something that comes back pretty quickly. And on lower doses, you can begin to see it color again. So, but don't equate that again with the efficacy. You may be, yes, having less of a concentration in your body, but maybe that's right for controlling the disease, at that time.
Well, thank you so much for your time. I also want to plug that while some of the research may not be conducted in clinical trials, we are also collecting data as part of our patient registry that does get at maybe some of these side effects and whether things get better for certain patients and what demographics are those patients. So that's also a little plug for our registry.
Well, I think it's critical, and I think that's where, in part, a lot of the answers are going to come from. So I really would encourage people on drug to participate in the registries and all of these programs, because we're only going to learn collectively, right, by what people are going through. So that's really important.
Thank you so much for your time. I also, if you want to stay on briefly, have a quick question, just a specific one that I can share later. And then for everyone else, we will have repeating and more webinars with Clinical Trials 101 being in May, and in June, we're doing a consensus paper webinar. So please check back on your webinars, and thanks everyone for joining.
Thank you, everyone.